Hello, and welcome to our presentation on the pharmacogenomics of tacrolimus and CYP3A4 metabolism, presented by Hamza Ali, Nico Conforto, and Van Vo.
The content include defining pharmacogenomics, clinical use of tacrolimus, metabolism of tacrolimus, pharmacogenomic evaluation of tacrolimus, and patient case. In this presentation, we will discuss the clinical use of tacrolimus and how it may be affected by genetic variations present in patients through effects on metabolic pathway. In addition, the overall genetic study of tacrolimus will be described, followed by a patient case as well. So, what is pharmacogenomics? Pharmacogenomics is defined as how an individual's genetics may affect the clinical effectiveness of the medications being utilized to treat a specific type of medical condition. What is tacrolimus for? Tacrolimus is classified as a calcineurin inhibitor that is utilized in a long-term immunosuppressive therapies for individuals who have underwent a solid organ transplant in hopes of mitigating potential immune system reactions caused by the transplantation itself. Now let's talk about metabolism of tacrolimus. Tacrolimus is metabolized through CYP450 enzymes. One of the more important types of CYP450 enzymes being CYP3A5, which will be the enzyme discussed in this study.
Pharmacogenomic evaluation of tacrolimus consists of a multi-step process involving evidence-based data, genetic testing, electronic health record and clinical decision support documentation, the evaluation of the program, and educating patients and physicians. When it comes to the drug-gene interaction, there are strong recommendations in the 2015 CPIC guidelines on therapeutic dosing for tacrolimus based on the type of metabolizer determined by genetic testing, which can include extensive metabolizer, intermediate metabolizer, and poor metabolizer. The testing would be covered by insurance when deemed medically necessary, and without insurance, a single test would be expensive, and some of them are upwards of $500. Medicare is known to cover this type of genetic test, as well as Blue Cross Blue Shield after a prior authorization, which may take some time. The program would inform practitioners of the correct therapeutic dose adjustment if a patient's CYP3A5 phenotype is known. That means if they are known to be an extensive metabolizer, the physician would know to either multiply their dose by 1.5 to 2. The other portion of the program would inform practitioners when tacrolimus is not obtaining its therapeutic effect and all other causes have been ruled out, such as medication interactions. This may also include a patient experiencing rejection. In a case where a patient is taking tacrolimus at home, the CDS would fire when the patient reaches their first refill. If they are at their first refill and still not meeting that therapeutic effect, which should be at full after 3 weeks of use, then we would consider whether or not the medications interacting are causing a problem or determine if a genetic test is needed. The program will be closely monitored for at least 1 year after its implementation to ensure all parameters are met and its overall effectiveness. Parameters could include anything to why the testing was done, when it was done, and what the clinical decision was based on the test. A section of the program will be dedicated to patient and physician education on the drug-gene interaction so that clinical decision-making can be shared. And it will also ensure that physicians are informed of the drug-gene interaction and know what to do with the information given on the test when it is complete. For patients that undergo this type of genetic testing and have a result that includes a dose adjustment, we will provide all the necessary information, whether it be counseling or a patient-friendly handout that will give all the specifics to why the genetic test was done, all the way to the dose adjustment made, so that they can understand the adjustment just as much as the physician.
Okay, so now I will be talking about a patient case regarding the pharmacogenomics of tacrolimus and its respective CYP3A5 metabolism. So this is the patient that I will be using as the example. So just some characteristics about the patient. The patient's name is Tyler Smith. The patient is 43 years old. The patient is male. The patient weighs 77 kilograms. The patient's height is 5 feet 10 inches tall. And the main indication is that this patient has recently underwent a kidney transplant. So now I will be talking about some background information about this patient for the case. So Tyler Smith, a 43-year-old African American male suffering from uncontrolled hypertension and type 2 diabetes, had recently developed a severe case of glomerular nephritis and required a full kidney transplant. Due to the kidney transplant, one of the main medications the patient is determined to be started on for chronic treatment is tacrolimus for appropriate immunosuppression therapy. The patient does not have any other underlying medical conditions other than uncontrolled hypertension and type 2 diabetes. However, the patient does have an allergy to sulfa, in which the patient developed a severe skin rash. Lastly, it is known that tacrolimus is metabolized through CYP450 enzymes, which includes CYP3A5. Thus, it has been recommended by the medical team to have the patient initiated on pharmacogenomic testing for CYP3A5 enzyme. So now I will be talking about the method of genetic testing. So the research team will initiate pharmacogenomic testing of this patient regarding the CYP3A5 enzyme through the collection of blood sample from the patient. Once the sample is collected, the genetic testing will be run and the results will be entered into the electronic health record system for appropriate documentation. Depending on the results of the patient's genetics, the appropriate dose of tacrolimus will be implemented for this patient. Now I will be talking about this patient's genetic characteristics and the implementation. The research team has successfully collected the appropriate blood sample and ran the genetic testing for this patient. After a few weeks, the test came in, and based on the results, it had been determined that this patient is classified as an extensive metabolizer CYP3A5 expressor. This was determined because this patient is an individual that has two functional alleles, star 1, It has been further determined by CPIC guidelines that this patient will require dose adjustments since this patient is an extensive metabolizer and will not reach ideal concentrations of tacrolimus, which will require a higher dose for this patient. Lastly, now I will be talking about the therapeutic recommendations for this patient. The therapeutic recommendations, as determined by CPIC guidelines, is to increase the dose 1.5 to 2 times for this patient, and the total starting dose should not go higher than 0.3 milligrams per kilogram per day. Furthermore, it is imperative to utilize therapeutic drug monitoring in order to assess potential risks of toxicities, which may lead to further dose adjustments if needed. The evidence level is strong for this recommendation. Finally, here are the resources that were used in order to construct this presentation regarding tacrolimus and CYP3A5 metabolism when it comes to pharmacogenomic testing for patients.